Good morning, guys. Today we can see like on 15 to 25 3D questions. Okay. See, a 52-year-old man presents for colon cancer screening. He is asymptomatic and he states that he is not aware of any family member with a prior history of either colon cancer or colon polyps. The patient undergoes colonoscopy and is found to have the following polyps and histological diagnosis: 2 mm cecal polyp, and 4 mm transverse polyp, tubular adenomas, low-grade dysplasia, 6 mm sigmoid polyp, tubulovillous adenoma, low-grade dysplasia, and 3 mm rectal polyp, hyperplasia. If those four lesions were completely removed, what should you recommend for ongoing colon surveillance? See, these type of four polyps are there. The options are colonoscopy in 1 year, colonoscopy in 3 years, colonoscopy in 5 years, yearly fecal occult blood test, and colonoscopy in 5 years. What can be the answer? It's no idea. So you can see the answer. Answer is colonoscopy in 3 years. Okay. So hyperplastic polyps do not infer an increased risk of colon cancer. Therefore, rectal lesion is of no clinical significance. The patient had 3 clinically significant polyps. See, we have 4 polyps, right? One at cecum, one at transverse, another one at sigmoid, another one at rectum. Among these four, rectum has hyperplasia. It is not a significant, they are saying. Although each lesion was smaller than 1 centimeter, the interval to be next colonoscopy would be 3 years because there were 3 or more polyps and because of one of the lesions had villus component. Cecal has tubular. Cecal polyp is cecal polyp, but the transverse is tubular adenoma. Sigmoid is tubulovillus. So villus, I think so. Villus is the main pathology here. See, they say because one of the lesions are villus component, so we have to see colonoscopy for 3 years. They are saying, and also all lesions are less than 1 centimeter. Why do we study anything like this in Saturday, right? I think so. Colon cancer. We can see. Yes, we don't have more stated to that. See, for in colorectal cancer, most common type occurring site is rectum, and most common is villus. Like in polyp, tubulovillus, and villus, most common risk is villus. And the genes are familial adenomatous polyposis, H and PCC, right? So for familial adenomatous polyposis, we have APC gene in chromosome 5, and for H and PCC, we have like mismatched repair, MSH2 and MLH1. Protective factors are like NSAIDs, like COX2 inhibitors, like celecoxib, aspirin, and antioxidants and metformin. This much enough, I think so. For colon cancer, actually study, but if I get okay. See, we're staging all of. For colon cancer, just remember this: we can give chemo. Okay, chemotherapy. The regimen is Folfox. See if we can say short. Okay, if the patient presents with the right side or left side lesion. For right side, what is there? Right side there is a cecum, right? And left side is a sigmoid colon. So for right side, the patient may right side colon cancer. The patient may present with like anemia, melena, moss. For left side, like obstruction. So obstruction is the AD presentation and or endophytic or like constrictive type. But on right side, exophytic or cauliflower type, like ulcers. Okay, so the main complaint is bleeding for rectum or tenesmus. Tenesmus means feeling of incomplete evacuation or altered bowel habits. So if they are coming like this, first we have to do a perectal examination. The perectal examination consists of two things. One is digital rectal examination and proctoscopy. Okay, so if the perectal examination is normal, then we have to do a sigmoidoscopy. If the sigmoidoscopy also normal, then we have to do colonoscopy. Okay, but in case that in PR we get a growth, then we have to do biopsy. After that, we have to do a colonoscopy. Whatever there may be, we have to do a colonoscopy. And in some other pathology, if there's a hemorrhoid means, we can do a treatment. Okay, so in colonoscopy, if it is not possible means then we can do a CT scan. Okay, so in colonoscopy, if in growth also we get a biopsy now. Biopsy also it confirms a cancer, and also colonoscopy we see a lesions like ulcerative, like lesions or like obstructive lesions. Then we confirm mainly through biopsy, and also again confirming with colonoscopy we confirm it's a cancer. Then we have to do staging. So tumor, node, metastasis, right? If it is a rectal cancer means we can do a transrectal USG or endorectal coil MRI. That is for rectal cancer we can do both USG and MRI. Okay, so if we are doing MRI means it gives details about depth of penetration and any perirectal lymph node spread like that for rectal cancer. Then for like staging we can do a CT PET, and also for here tumor markers are present. That is carcinoembryonic antigen. Tumor markers also present. The name of the marker is carcinoembryonic antigen. And also we can do for H&PCC now. We already saw that mismatch repair. So mismatch gene repair like microsatellite instability testing. Like we can do a genetic testing for mismatch gene repair. Okay, that's it. Like in like tumor, if in case of rectal cancer we can do USG or MRI. In case of any node metastasis we can do CT PET, and again for tumor marker and also for genetic testing like mismatch gene repair. These are the things. So if we found it is an advanced case, then we have to check for some receptors, BRAF like mutations, BRAF mutation, KRAS and HER2 See, like breast cancer we have BRAF and HER2, right? Like here also BRAF, KRAS and HER2. We are before we used on staging Aster color or Duke staging, but now we are using TNM staging. Okay, so TNM 1 2 3 4 1 and 2 we have section A and B. See, like T1 T2 T3 T4, like 1 2 3 4 1 we have 1A 1B 2A 2B. See, first 1A to 2B, T1 T2 T3 T4. Okay, then stage 3 and stage 4. For stage 1 surgery, stage 2 surgery plus chemo, stage 3 neoadjuvant surgery chemo, stage 4 is a metastasis, is involves a complicated process. Stage 1 surgery, stage 2 surgery plus chemo, stage 3 neo surgery adjuvant chemo, stage 4 something big, that is we have to resect, palliative resection, and also we have to do metastatectomy if there is a liver. In liver mostly the colorectal cancer it will be spread to liver, so we have to do a metastatic lies a lung, liver nodule or multiple nodules in one segment of liver, that is left lobe of liver. Like we have to dissect like a segment. Next, chemo and target therapy. For chemo we studied in a FOLFOX. See here, for third stage we use a chemotherapy FOLFOX, but the fourth stage FOLFIRI. Okay, for FOLFIRI, F fluorouracil, L leucobarine, F folic acid, I or I irinotecan. There FOLFOX means FOLFOX, F fluorouracil, O oxaliplatin, F folic acid, oxaliplatin. FOLFOX. So there F4 means fluorouracil. Okay, L means leucobarine. And for target therapy, we can for BRAF positive we can give patritumab, KRAS positive cetuximab, and for HER2 positive Herceptin, this trastuzumab, and for MMR or MSN positive we can give nivolumab or ipilimumab. Nivolumab or ipilimumab. See, for BRAF positive we can give BRAF BP patritumab. Okay, for KRAS cetuximab, KRAS actually cetuximab, KRAS. King. For king setup it is more difficult, right? Setup cetuximab, KRAS, and HER2 H has Herceptin. Actually it's a difficult, right? So more difficult, but okay, it's okay now. Whatever the case, you have to do a colonoscopy. In case of rectal cancer we can do both USG and MRI, but for malignancy first stage we have to do a CT PET, and also for tumor markers and also genetic testing. In case of like four genes now, BRAF, KRAS, HER2 and also mismatch gene repair. For BRAF BP patritumab, and for HER2 Herceptin, and for KRAS cetuximab, king. Setup is difficult, so cetuximab. And for mismatch gene we have so nivolumab ipilimumab. Okay, why you are studying the colon cancer? Okay, So here colonoscopy in 3 years. Next, a 42-year-old female diagnosed complaints of anogenital warts. A 42-year-old female diagnosed complaints of what anogenital warts. For undergoing therapy for its removal, and she has developed a particular fear of viral diseases after her diagnosis and wants to get vaccinated for COVID-19. So the following is true regarding this patient. See, she is getting another warts, but she is complaining of getting viral infections. Okay. Next, annular warts are an active infections and may not be treated at the earliest. Which is true, you're asking, which is true. Anogenital warts or an active infection that can be treated surgically only. Underlying papillomavirus may spread to another person via a fecal-oral route. COVID-19 live vaccine is contraindicated in this patient as she is already suffering from an active infection. See, COVID-19, Covishield, right? Covishield or Covaxin. It's then we can't give the vaccine. Sorry guys, we can continue this video, okay? So any live vaccine should not be given in an immunocompromised patients. Okay, so here the anogenital warts, she's having a disease now, so it should not be given. See, the anogenital warts are an active infection and may not be treated at the earliest. Or an active infection that can be treated surgically only. I think so. Warts like laser excision, right? Underlying papillomavirus may spread to another person via fecal route. Is it right? Fecal route? I don't think so. Next, a 67-year-old female with a history of hypertension and hyperlipidemia presented to the clinic with worsening fevers, cough, and respiratory distress. She gives a history of contact with a diagnosed case of COVID-19 1 week ago false regarding the replication of SARS-CoV in host cells. See, there are no need. They are asking regarding the SARS-CoV, what is false regarding replication. So, attachment with the host cell receptor is the initial step in replication cycle via S protein and ACE2 receptor interaction in type 2 pneumocytes only. See, like they are saying, the SARS virus, it is attached with the host cell receptor. Is the initial step in replication cycle via a which protein, S protein and ACE2 receptor. That is astrogenesis like that. 2 receptor interaction in type pneumocytes. So they are attaching to type pneumocytes. Proteins, S protein and ACE2 receptor interaction. Okay, they are saying it, but it is true statement. Penetration of virus into the host cell occur via endocytosis. This is also true. And at the end of replication cycle, virus is released by lysis of host cell. Virus is released by the lysis of host cell, like it is saying, but it is a false. See, here saying all enveloped viruses are released by budding from the host cell. Envelope is contributed by host cell membrane. So all non-enveloped viruses are released by lysis of host cell. So if like they are saying envelope present means they are released by budding, leaving the envelope, like the envelope is contributed by the host cell membrane. Okay, so SARS coronavirus has an envelope, right? It is an RNA virus. Yes, it is an enveloped RNA virus. So no lysis, so it is a false. But see, here the penetration of virus into the host cell occurs via endocytosis is a true statement. Okay. Next question. A 66-year-old woman with pulmonary fibrosis present with a complaint of increasing dyspnea while performing activities of daily living. She is referred for pulmonary function testing to assess the progression of the disease. Which of the following laboratory values is consistent with her diagnosis? So what's the diagnosis? A case of pulmonary fibrosis having like daily activity distress. Now she is going for pulmonary function test. First, what is pulmonary fibrosis? It is an obstructive or restrictive disease. It is a restrictive disease, right? Like interstitial disease, so it's a restrictive disease. So like main thing like FE1 by FEC almost normal because both will be reduced. Force expiratory volume also reduced and force expiratory vital capacity also reduced. So it will be normal. See here, what is true? They are asking what is true. See, decreased diffusing capacity of the lung. Diffusion coefficient, right? Diffusion capacity of the lung. Yes, here the pulmonary fibrosis, so the diffusion capacity will be decreased. So it's a correct. Increased residual volume. Why doesn't increase volume? Obviously, it will decrease volume, right? So here is saying increased residual volume is wrong because all the lung volumes will be decreased along with capacities, right? Next, decreased force expiratory volume exhaled in 1 second by force vital capacity. No, it's normal. In all expiratory cases, we will get FeV1 by FEC is normal, so it's false. Increased airway resistance factor for lung volume. What that means? They are saying increased airway resistance. So airway radius is decreased and thus airway resistance is increased at lower lung volumes but in restrictive disorders. The airway resistance is normal when corrected for lung volume, in contrast to obstructive disorders in which increased airway resistance is a hallmark of functional impairment. Like in obstructive disease, there will be reduction in radius of airway, so there will be increased resistance. But in all restrictive diseases, the airway radius will be normal, so the airway resistance also normal. So it's a false statement. Okay. Next question. A 30-year-old male is found unresponsive outside a supermarket. The emergency response team finds him in ventricular fibrillation. After 10 minutes of CPR, the emergency response team is successful in reviving the patient. In emergency room, it is decided to cool the temperature to 34 degrees Celsius from 37 degrees Celsius. By this measure, the cerebral metabolic demand will decrease by like how much percentage? They are cooling the body from 37 to 34 degrees Celsius. So the cerebral metabolic demand will decrease by, see the answer is 18% on it. Like a statement. Cerebral metabolic rate decreases by 6% per degree Celsius from a decrease in body temperature below 37 degrees Celsius. So from 37 here 34 degrees Celsius is decreasing. So 37, 36, 35, 34. So 3 degrees Celsius decrease. Per degree 6%, so 18%. Okay. This I also become somewhat difficult. It's a neat PG mock exam. So 24. Okay, next. Can you see the diagram? Okay. Yeah, 56-year-old male patient presented with increasing anorexia, loss of appetite and fatigability. Physical examination shows see the male patient anorexia, loss of appetite. Okay, shows a hepatomegaly and lab findings will increase bilirubin 2.6. And radiologic investigation shows a mass lesion in the liver, which shows a hyper enhancement during arterial phase and washouts in the venous. And to know the nature of the mass, a biopsy was performed. Image of which shown below. Based on above finding, all the following statements are true regarding the diagnosis except. So what's the diagnosis? I think so hepatocellular carcinoma. Loss of appetite, okay, and also hepatomegaly, bilirubin, jaundice, and see the main thing here is there is an enhancement, hyper enhancements during arterial phase, and washout, rapid washout in the venous, right? So it's a hepatic cell carcinoma. So what is false they are asking? First, well differentiated form typically shows the hepatocyte plates are more than 3 cells wide. So in any cases, like the cell should be taller than width, right? So here they are saying that cells are taller than this. But see here actually it's a well differentiated, not ill differentiated, right? So well differentiated. Okay. Can you see? Okay. Next, tumor cells are polygonal in shape as hepatocyte with abundant eosinophilic cytoplasm with round nuclei. Actually here the cell morphology is not destroyed, so it's true. Like the cells are like actually the hepatocytes are polygonal in shape, so the cell shape is maintained. Some of the tumor cells show intranuclear pseudo inclusion. Is also true. Tumor shows extensive stroma with marked fibrosis. Actually, it's a bit difficult. Actually, first we can go how the HCC will look like. Okay. See, in HCC, microscopically well and moderately differentiated hepatocellular carcinoma are composed of cells that resemble a normal hepatocytes. So they are resembling like normal hepatocytes, while poorly differentiated tumor cells mark the cytologic ATPR. Okay. So a feature of great diagnostic significance in well differentiated is the thickness of trabeculae. So in well differentiated cases, the trabeculae will be thicker and we can better evaluate in reticulin stain. And also the hepatocytic plates are typically more than 3 cells width. The taller is more than 3 cells width. So they are saying in between the hepatocytes the trabeculae will be more thicker. And also we can see these cells in HE stain, that is hematoxin eosin stain, but we can better see in reticulin stain. And also the hepatocytic plates are much taller, that is more than 3 cells width. Okay, the next thing is the stroma. The stroma is usually scant in contrast to that of cholangiocarcinoma. So they are saying the cytoplasm is scant. Stroma is scant. And tumor may exhibit intranuclear pseudo-inclusions caused by cytoplasmic invaginations. The cytoplasms are invaginated, so it appears like a pseudo-inclusions, which are seen in well-differentiated hepatocellular carcinoma. And the stroma, that is the outside the cell space now, is ideas, there will be no place in HCC. Okay, so here see the false statement is here they are given tumor shows extensive stroma with marked fibrosis. So it's a false statement, right? Actually, it's a bit difficult, but we can rule out if we know the HCC, right? Next, Indian working in a COVID ward is recommended to sanitize the hands with a hand rub in all the following scenarios except before and after touching the surroundings of the patient. Yes, we have to wash. Before and after performing clinical procedures on patient. Yes, we have to wash. Next, whenever the hands are visibly soiled, we should do no, right? Next, a patient presents with painful sudden loss of vision. Painful sudden loss of vision. He also complains of pain on ocular movement. Most likely diagnosis. Actually, why is I seems it's very difficult, like because the options are retrobulbar neuritis, craniopharyngioma, eosinosis, optic nerve glioma. Can anyone do that? Uh, Painful sudden loss of vision. See, craniopharyngioma, right? It's a supercellular tumor. If it compresses the optic chiasma, means there will be bitemporal hemianopia. Like so, it's not an option. Actually, see the retrobulbar neuritis means inflammation, right? And also, it's inflammation, so painful. Okay. He also complains of pain and arterial movement, so retrobulbar neuritis. We can assume that, and we can see some points later this. Okay. So we can see a Marcus can pupil here, right? Ill-defined pupillary reaction, and also the depth of perception of moving object is impaired. In optic neuritis, the moving object depth of perception is impaired. This is called as pull-fritz phenomenon. We can call this as pull-fritz phenomenon. Okay. No need. Next question. See, so much argument. We don't need. We can straight away go to abdomen G3 patient. Okay. Sorry, G3 matter. Abdomen examination. So fundus in between the umbilicus and staphysternum. Umbilicus and staphysternum. Okay. Vertical eye, safari presentation, head engaged, FS are okay. PV, so cervix soft, FAS, the 4 cm dilated, 2 cm long, head at station -1, head at -1. And the membranes intact, all the following could be a cause of this condition except. See, all are okay. Right? But the feet, here they are given 30 weeks. So 30 weeks, approximately for 24 weeks, I think so. 20 weeks at umbilicus, right? So it will be above umbilicus plus below umbilicus, but all the features are okay. So COVID-19 infection, no. Uterine anomalies, no. Twin gestation, no. Oligohydramnios. Next is a medicine, lung question. See, a 66-year-old up to we have started up 56 like questions. We can say up to 75. Okay, that's enough. Next, a 66-year-old chronic smoker present with shortness of breath and chronic cough. On examination, he appears thin-built and has pursed breathing. Lung examination reveals barrel-shaped chest. I think so. COPD. Inspiratory wheeze and hyporesonant fields are appreciated. Okay, the patient is taken for pulmonary function test by the resident. The test would reveal all the following conditions except. So COPD is an obstructive or restrictive? It's an obstructive, right? See, first they are given decreased vital capacity. Hmm. Yes. In COPD, I think so. The capacity is decreased because COPD comprises two things, right? Emphysema and chronic bronchitis. Here, the situation is more acute emphysema. See, we can see a basic things. First, we can see, right? In COPD, the vital capacity is decreased, but total lung capacity is normal. And forced expiratory volume is decreased, and forced vital capacity is decreased. And DLCO is decreased. See, I have some doubt like why force vital capacity is decreased but total lung capacity is normal. We can see, right? Wait. No, 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 no. Where did I study? Where did I study? See, in obstructive diseases, the diffused lung, that is the diffusion coefficient, diffusion of gases, DLCO, is normal. In asthma, the diffusion is normal. This diffusion, how can we say, diffused diffusion coefficient, right, is normal. In bronchitis, it is normal, but in emphysema, it is decreased. Why it is decreased? So totally in COPD also it is decreased because in emphysema, the surface area is decreased. Why? Because the alveoli all are damaging, right? So the diffusion of gases will be impaired. The area, surface area is decreased because of the destruction of the alveoli. So the diffusion will be decreased in COPD. Okay. Next, why did the vital capacity is decreased? Right. If you are given it may be normal or decreased capacity, right? So it may be normal or decreased. but the total lung capacity is increased. So it's the main thing we have to remember, right? Like vital capacity is decreased, but the total lung capacity is normal or increased. Okay, where we can see now. See here, the decreased vital capacity is normal. Okay, right? Increased DLCO. No, DLCO is decreased. So it's wrong. Next, increased total lung capacity is right. Decreased FE1 by FVC ratio is right. In obstructive cases, FE1 by FVC is decreased, but in restrictive cases, it's normal. Okay. Next, a man working in a factory that manufactures or storage batteries develops headache, weakness, abdominal cramp, and constipation, joint and muscle pain. On examination, pallor is present. A blue lines is seen in the gums. It's Brutonian line, right? Where can we see this? Like we have three metals like arsenic, lead, and mercury. In lead, we can see Mies line, right? I think so. Mercury. No, it's a lead. Ha ha. How can this go wrong? Arsenic. Oh, in arsenic only we see the Mies line. Yes, I like Mies. Yes, arsenic. C S E. Okay, Mies line we see in arsenic. Arsenic, lead, mercury. So like Brutonian line, which is seen in like mercury. So let. Why I am like this confused? Okay, you can see here. Always forgetting these little things. Arsenic, mercury, lead. So in arsenic we get like acute and chronic. In acute we get cholera-like symptoms, and in chronic we see raindrop pigmentation, bile, hyperkeratosis, Mies line, and neuropathy. Like and also paper gangrene. Okay, and in mercury weak metal, right? Many meta disease, erythema, tremor, acrodynia, and lentis. Anti-lentis capsule. In lead, plumpism only we get Brutonian lead only A, B, C, D up to G. So lead, although it is smaller, we see A, B, C, D, F, G. A, anemia. B, bone line or lead line, Brutonian line, basofilic stripling. C, corbett, like colics and corbett rings. And D, epicem like wrist drop, dropsy like wrist drop. E, encephalopathy. F, G, F. Facial pallor. G, gout. Always metal is mercury is metal. M, meta disease. E, erythema like neurological manifestations. T, tremor. A, allodynia, that is painful peripheries, scalping disease, or Schiff's disease, or Calamal disease. Okay, L, lentis, anterior lens capsule, Brown's deposits. Later, arsenic we have to acute, chronic. Acute is similar to like cholera, and chronic we get bilateral hyperpigmentation. This raindrop pigmentation and bilateral hyperkeratosis of palms and soles, and Aldrich Mies line on the fingers, right? Yes. Okay. Very good. So here see headache, weakness, abdominal colic, constipation, muscle pain, pallor is present. F, facial pallor, blue lines on C on the gums. So later, the following is most appropriate in this type of cases of poisoning. So which is true. The arsenic is true. Copropurpurine in urine is a confirmatory test to detect this type of poisoning. Is it a copropurpurine? Lead. I think it's okay. Next, the concentration of this element in the working atmosphere should be kept below 2 mg per 10 cubic meters of air. I don't know. Presence of this element in urine at any level has no association with possible. What? Presence of this element in urine at any level has no association with possible exposure. How it will be no association? It will be an association, right? So it's a false. The poisoning is notifiable but not compensable disease in India. Not compensable? How? It will be compensable, right? I think so. False. See, the concentration of lead in the working atmosphere should be kept below 2 mg per 10 cubic meters of air. It's a law. So it's a right statement. And also, they are given copropurpurine in urine is a screening test, not a confirmatory test. Okay. So some important points. Lead poisoning, also known as pluralism, is seen among the workers employed in manufacture of storage batteries, glass manufacture, shipbuilding, printing and pottery, rubber industry. And the increase in concentration of lead in blood is 70 microgram per gram is associated with clinical symptoms. So more than 70 microgram is a defect. Okay. So copropurpurine in urine is a screening test, not a confirmatory test. And lead poisoning is notifiable and compensable disease in India since 1924. Okay, they are given a proper explanation. I hope you can understand something. Next, a 19-year-old girl complains of skin problems and is noted to have erythematous papules on her face. With the black heads, like communes and white heads, closed communes, she has also have cystic lesions, and she's prescribed a topical retinoid, but without a totally acceptable result. The following is correct. See, she has papules and blackheads. Like in a pimple treatment, if you are having a comedone means a topical antibiotic. Comedone is plus papule, topical retinoid and topical antibiotic, and comedone papule and pustule means a systemic antibiotic. And if the nodular cystic lesions means additionally you have to use systemic retinoid. I have one doubt whether we should give first topical antibiotic or topical retinoid. Holy so doubt. Okay, in first communal case we have to give topical retinoid. So start with topical retinoid, only topical antibiotic. Okay, so here we can see papules, comedones have cystic lesions. So I think it's the last stage, so we have to give isotretinoin systemic also. So it is correct they are asking. Intralesional triamcinolone should be avoided due to its systemic effects. Why triamcinolone? Like it's not a collagen, right? Like collagen disease, so we don't need that. Systemically administered isotretinoin therapy cannot be considered unless concomitant contraceptive therapy is provided. No, we can give. In contraceptive therapy, I think so. We can give. While in pregnancy only we can't give. Antimicrobial therapies of no value since bacteria are not part of pathogenesis process. No, we should give antibiotics. Isotretinoin is without impulse side effects as long as it is not used sexually active in women. Isotretinoin is without impulse side effects as long as it is not used in sexually active women. Yes, we shouldn't give in sexually active women, right? So it's okay. Last one is correct. Okay. Can you see some image? Okay. X-ray given. What is the diagnosis? I won't have enough to study the question. So based on this, it's what vertebra? It's a radicular spine, so it's in hyperparathyroidism. So the answer is osteoarthritis fibrosis cystica. Like in Paget's disease, we get picture frame. All four sides, also whitened. Only the center is black, right? But here only the above and below. So Jepkes is a osteoarthritic fibrosis cystica. Okay, next is, can you see the image? So given a firm, smooth, yellowish submucosal mass in the stomach, and it's a smooth muscle, like, right? History examination shows below. All the following statements are true. I think so. Just what is false? You're asking. See, these tumors are mutation in the receptor tyrosine kinase kit. Is right. The tumors is mostly composed of pin elongate spindle cells, right? The immune system CD117 positive is right. CD117 dog and c-kit STH are positive, and it is originated from mucosa. No, the bad is originated. It is originated from the pacemaker cells of Golgi. Okay, so it's a wrong statement. 70. I think so. 70 is enough. I don't have any energy. Okay, 70.